So this lecture is an introduction to veterinary neuro-ophthalmology and is also the first in a series of lectures explaining testing of cranial nerve functions. So our aims for this lecture are to better understand the key structures in the visual pathways, to understand the key structures in eye movement and the testing to evaluate these. Now, this is a section of my neuro exam sheet which can be downloaded from my website neurovet.co.uk, and this is the test that we're going to talk about here. The first one is, can they actually see? Do the animals have vision, and is that vision present in both eyes? I like to do a tracking object test. Some veterinary textbooks diminish the value of this test, but I still think it is useful. I'll use a cotton wool ball. This is because bright white is easier for animals to see. Obviously cats and dogs have a muted colour vision compared to us, and it's also soundless as it drops. We want to drop it either side of the head so that we can assess vision in each eye. And I think even from this picture we can tell that this cat is seeing this object here. The next most important test is the Menace response. And this is useful for vision assessment, but you must bear in mind that this involves many other areas of the brain, in particular the cerebellum, and also the facial nerve and nucleus. And so an absent Menace is has to be interpreted in context. Also, I want to point out that this is a Menace response. It is not a Menace reflex. There's quite a difference between the two. A reflex is a very short circuit with one sensory arm and maybe a little bit of integration in between, but then a reflex motor arm. This is a response which accounts for a large amount of processing in the brain. It is also something that is learnt, so you don't see it in young cats or puppies. It generally occurs developed at about 12 weeks of age. And then we have the pupillary light reflex. Now, the pupillary light reflex does not assess vision, but the photoreceptors for the pupillary light reflex are on the retina. The nerves travel through the optic nerve, optic chiasm, and then go on to the brainstem. So there is a commonality there with the optic nerve photoreceptors for vision. And so this test is very useful for localizing the blindness. And if both the pupillary light reflex and vision are absent, then this would suggest that the blindness is the eye, the optic nerve, or the chiasm. So here is an example of a kitten where I found tracking versus Menace to be useful for assessing the vision. This kitten was presented obtunded and tetraparetic with this extensor posturing, which suggested to me that he may have brain disease or brainstem disease, and so obviously I was doing a neurological exam. And we can see here, although the cat is looking at me, the Menace response is difficult to elicit. However, when we drop cotton wool balls down, we can see that the kitten definitely can see. And the end result was that actually this cat didn't have forebrain disease or brainstem disease at all. It had empyema, had an abscess. This was probably a penetrating stick injury or something similar, something going up through the pharynx here, and an abscess that was at the craniocervical junction. Of course, this may have been resulting in some kind of toxicity, etc., in the brain, which may have accounted more for its obtundation. But there was no visual deficit, and in this case, the tracking helped confirm that. Doing a Menace response in a cat can be quite challenging. Look at this cat. This cat has central blindness and a Menace deficit on the left. But when the operator flaps her hand in front of the cat, then it looks like there is a Menace response. Watch again. So the cat is blind on the left, no response there. no response when she uses a finger, but when she flaps her hand, there is an apparent Menace response, except that isn't a Menace response. That's a palpebral that she's generated by making an air current and stimulating the whiskers. So Menace response can actually sometimes be quite challenging in the cat. And the other area is that you can be fooled is when the animal has cerebellar disease. So when you have cerebellar disease, you don't have a Menace response. And just see there, when I go to a finger instead of flapping my hand in front of the cat's face and stimulating a palpebral, as in the last cat, say there, it looked like it was a Menace, but it was a palpebral. You can see that there is no Menace response, but the cat had a quick look at my finger there, showing that he does actually have vision. Just there, see? And this cartoon is showing us the Menace response very basically. So it requires an intact eye, an intact optic nerve, an intact optic chiasm. The thalamus needs to go to the visual cortex. Bear in mind this is a cartoon, that's not the way it really travels. Especially doesn't go in a straight line like this through the visual cortex, goes through the white matter. So from the visual cortex to the motor cortex down to the pons, influenced by the cerebellum, facial nerve nuclei, and then we have the facial nerve. So this is really quite a complicated response, and you need to interpret where in this pathway it is lost. So our other test that we can use for vision and visual pathways is negotiating objects. So this is another cat that was very difficult to elicit a Menace response from, even though she was visual in one eye. And we can see her successfully negotiating her way to her caregiver there. And this, she knows that this is her box, and we can appreciate that she can see that. Yes, she wants to jump in. The same cat here is showing a Dazzle reflex. So Dazzle reflex is when you shine a very bright light into the eye, and you get the eye closing. It's a pretty limited in its use, the Dazzle reflex, because it's a subcortical reflex. It's thought to be optic chiasm to rostral colliculus to the facial nerve nuclei, but we're not absolutely sure. And so it really doesn't show that we have vision at all. And in fact, I've seen a Dazzle reflex be preserved in a cat that had almost was completely blind centrally, and also it will preserve shortly after euthanasia. Even it's one of the very last reflexes to go. So when an animal is dying, it is one of the last reflexes to be lost. So if you've established that the animal is blind, your next thing to establish is, are the pupils abnormal or normal? And this is what I was talking about before. We need to decide whether the blindness is because of an eye, optic nerve, or optic chiasm lesion, an optic tract lesion, or further on in the visual pathways. So the visual pathways starts at the optic nerve, goes through the optic tract to the thalamus and up to the visual cortex. However, the pupillary light reflex has a commonality just at the level of the eye, optic nerve, optic tract, and then it goes to the pretectal nucleus. Will decussate at that stage. Obviously, it would also decussate at the level of the optic chiasm. Then go to the parasympathetic nucleus of the oculomotor nerve in the midbrain, and then we will get closure of the pupil. So these are two very different things, but because they both involve photoreceptors of the receptor and the optic nerve and the optic chiasm and the optic tract, then we can get some localization of the blindness by comparing whether or not the animal is visual and whether or not there is a pupillary light reflex present. And we often use something called the swinging light flashlight test for this. So the principle of the swinging light test is that you swing the light between the eyes. So if I have an intact eye optic nerve and chiasm, when I shine a light into this eye, then because of the decussation here and here, I will get a constriction of the pupil in this eye. Likewise, if I go to this eye, then I should get a constriction in this eye. However, if there is a problem here, if there is a lesion right at the level of the optic nerve, then when I've shone a light into this eye, I get that consensual response, as it's called. But when I shine a light into this eye, that information from the light is not being transmitted down that optic nerve, and so this eye will actually dilate, as we will see in this video. So constriction, dilation, constriction, dilation. So this tells us that we have a lesion in that optic nerve on the left hand side. So what are our visual pathways? We start off at the optic nerve, and then we go to the optic chiasm, which is this slice here. We can just see the optic chiasm there. Then this will travel via the optic tract, and the optic tract is, you have to sort of imagine that it's sort of coming roughly in this region here. At this level it's about there, making its way to the lateral geniculate body of the thalamus, and it will receive about 80% of the optic tract, and the other 20% goes off to the pupillary light reflex, which of course is in the brainstem. Then that will travel through the internal capsule, which is called the optic radiation, and from there we'll go off to the occipital cortex. And there'll be eventually another YouTube video which will be describing central blindness, so look out for that one. So to illustrate this, we're going to look at a case example together. So this is a 7-year-old male neutered Tonkinese, and he's presented with a sudden onset blindness. So we evaluated the cat, and we actually found that there was a very subtle Menace response present on the left side. So, but he was completely blind on the right. So a very small amount of Menace here. Both the pupils were mydriatic. But when a bright light was shone in the left eye, you got a very small pupillary light reflex, which was direct and consensual. When a light was shone in the right eye, then we got nothing. And this was really a very tiny pupillary light reflex, so it was still regarded as abnormal. The ophthalmologist who saw the cat elected to give 1% pilocarpine. This is a dilute solution of pilocarpine that wouldn't normally expect to result in any change in the pupils. What change would you expect? You'd expect pupillary constriction. And this didn't make any response. The only instance that you would get a response if there was a phenomenon of denervation hypersensitivity, and that basically occurs when there's a damage to the postganglionic neuron, and means that you get an awful lot more receptors on the postsynaptic membrane, which means a dilute solution will have an effect. There was no response, so that we know that the cat isn't mydriatic because of damage to this part of the oculomotor nerve. Not a particularly useful test otherwise, but if you're wanting to be absolutely sure that the mydriasis is due to blindness, then this is quite useful. So how do we describe these pupils? Are they normal, constricted, dilated, or do they have anisocoria? Do they have uneven size? This is his pupil here. You can actually sort of see right back in the back of the eye, even without much magnification. Yes, so these are dilated in ambient light. And it's important to say, you know, what is the light conditions here? Is the pupillary light reflex normal? There's a number of options here. Which one do you think is the most correct? Yes, although there was a little reflex, pupillary light reflex on the left, it was still abnormal. So it is abnormal direct and consensual left and right with a slight reflex on the left. So we need to localize the visual loss. And these are the options: forebrain, left and right, right eye optic nerve, left eye optic nerve, both eyes optic nerve, or both left and right forebrain. Yes, so this is both eyes optic nerve, but there is some function preserved on the left. So how do we explain that? So the eye was mydriatic and blind. When we did a PLR, we got absolutely nothing. And no direct or consensual when we shone light in the right eye, and it was completely blind. So this puts the lesion either at the level of the retina, the optic nerve, or perhaps close to the chiasm, or incomplete lesion of the chiasm, because there was a little tiny bit of function on the left. The cat was still had only the barest of Menace responses and a very slight pupillary light reflex, suggesting that there was a partial lesion in this area, almost complete lesion. So of course we would want to do a retinal exam in that instance, and I have to thank Sheila Crispin, Natasha Mitchell, and most importantly this wonderful book called The Feline Ophthalmology, the manual, for this slide, which is actually not this cat's eye, but one that was very similar to our cat. There was a loss of detail of the optic disc due to a severe cellular infiltrate. And in our cat, we found that there was the retina had detached around the optic disc. There was retinal hemorrhage. This cat was feline leukemia positive on serology. We felt it was highly consistent with lymphoma of the optic nerve or chiasm. Main differential was optic neuritis. Why did we think it was lymphoma? Well, this cat also had an MRI scan, and you can see here his eyes here. These are the lenses. You see the iris here, and this is the more normal, not quite normal, but more normal optic nerve on the left here. And then this is the right here, which you can see is markedly thickened, and there's also marked thickening of the chiasm. And there were some changes, however, on the left eye, sort of closer to the origin of the eyeball. Wasn't completely normal on that side, and in any case, the involvement of the chiasm will have also been affecting visual pathways and PLR coming from the left. We also found changes in the brain, which would either suggest an inflammatory process not just involving the optic nerves but in the brain, but because of its kind of periventricular location, and some other changes, it was most consistent with lymphoma, although it was never actually proved. The CSF analysis was cell count was normal, the protein was markedly elevated, which is pretty common with lymphoma, and there was no other sites of disease found. This cat did fairly well in the short term on chemotherapy, but didn't had a kind of recurrence of signs within a few months. So our next question is, if the animal is visual, are the pupils normal or abnormal? So the pupils can be normal or abnormal even if the animal is visual. So here's our next example. This is a 10-year-old female cat, and the owner takes a picture and she's a bit concerned because one eye is very different to the other eye. So what do we call this? Is it normal, constricted, dilated, or is it anisocoria? Yes, this is anisocoria, so the pupils are uneven. So you do a pupillary light reflex. This is what you found in ambient light, that the right pupil was smaller than the left pupil, or the left pupil was larger than the right pupil, depending on your perspective. And when you shone a light into the right side, you got a pupillary light reflex that looked like this on the left and this on the right. And when you did it on the right, you got a fairly similar appearance. So the question is, what test should you do after that? These pupils are abnormal. And the answer is you should do something called a dark adaptation test. So you should put the animal into the dark. And of course, in the normal circumstances, the pupils should fully dilate and you should be able to see that tapetal reflex at the back, which is the handy thing about our cats and dogs, that they have this beacon which shows us the size of their eyes, and not something I think that humans have. We can see in this that the right side is still constricted compared to the left. So how do we describe this? So basically both of the pupils have dilated, but there is still anisocoria. One of them has not achieved the full dilation. So what is the most likely cause of this lesion? And the answer to that is D. There is a problem with the sympathetic supply to the right eye. And this is a Horner syndrome of the right eye. This lecture is really just to concentrate on the testing that you need to do for neuro-ophthalmology. If this is something that you don't understand, then I would suggest this video here, Making Sense of Horner syndrome in the dog and the cat. So our next testing is we need to decide, is the eye and the adnexa position normal? So this is a little bit more complicated anatomy. We need to understand the anatomy of the eye movements. And these are down to the extraocular muscles. And these are the medial, lateral, dorsal and ventral rectus, and then also the oblique muscles. And the most easy way to remember this is that the oculomotor nerve, and handily named because ocular and motor moves the eye, so it moves the eye on externally with these extraocular muscles, and it moves the eye internally, and that's the iris. So the oculomotor nerve does most of the extraocular muscles and also does eyelid elevation. In fact, the only major muscle that the oculomotor nerve does not do is the lateral rectus, the one at the side, and this is done by 6, the abducens. The trochlear nerve does the dorsal oblique muscle, which is a muscle which kind of twists the eyeball, and we're not going to talk about it much in this particular lecture because it's actually quite unusual to see a trochlear nerve lesion on its own in dogs and cats. It's more common in ruminants and horses because a trochlear nerve paralysis can occur when you have metabolic disease. But this will be the subject of a different lecture in more detail. And all of these nerves are coordinated through the medial longitudinal fasciculus, or the NLF. And that's really because you do need to have your eyes both pointing in the same direction. It's no good moving one eye and not moving the other eye, because then you will lose your binocular vision. And so we have this area here right on the base of the brainstem, which helps coordinate all of these movements along with the vestibular nuclei, so it combines it with our head position. So when we have abnormal eye movement of position, first of all, if it's an abnormal position, we call it strabismus. And strabismus is actually quite common in brachycephalic dogs. And this is often due to their malformed and shallow orbits rather than due to a neurological problem. And when it is like that in these brachycephalic dogs, you can refer to it as committant, non-paralytic. So there's a misalignment in all gaze directions. Every time you look at the dog, there is an abnormal position. It may be more abnormal in certain gazes, like become more apparent when they're gazing to the side of the strabismus. And this is usually a congenital problem, and it's a development of imbalance between the extraocular muscle tone and length. And it's never really understood in the brachycephalic dogs. I've never seen a good explanation for it, but I've always presumed that their extraocular muscles have just not developed normally because of the shallowness of the orbit and the protuberance of their eyes. Then we have incommittant, and the misalignment depends on the direction of the gaze, and this is due to specific muscle or nerve dysfunction, and we can describe that as paralytic. So this is where you have damage to those nerves that move the extraocular muscles, so 3, 4 and 6, or it could be due to vestibular dysfunction, which is obviously the cranial nerve 8. Or the vestibular apparatus. And in vestibular strabismus, we get a positional strabismus. And you can also have a restrictive one where there's a mechanical restriction. So we're just going to have a look at an example of that. So this dog has a left oculomotor nerve lesion, an external one and an internal one. You may notice that the pupil is mydriatic. So when we look at this dog here, we can see that the eyes are moving, but they are weak on the left side, tends to get left behind. Tends to get pulled laterally because number 6 is working and all of the others are not.
Look this way. Look this way. Good girl. Good girl. Look this way. Look. What's this?
And you can see when I call her that I make her look to the side, that pull by the lateral rectus becomes much more apparent. And this is something that's actually quite difficult to do in dogs. In humans, of course, you're asked to look to the left, look to the right. I always tell my optician how easy she has life. Just look at this again. So generally, the eye is not, on the left side, is not moving medially as quickly as as the other eye. And even in the up and down movements, just a little bit slower. But it's actually difficult to pull out that there is an oculomotor lesion, because she can move it a little bit, but when we call her,
hey, look this way, look this way, good girl, good girl, look this way.
You can see that the dominance of the lateral rectus takes over. Lateral rectus, of course, innervated by 6. And not being opposed properly by the other muscles, and you can see her eye is pulled laterally. So this shows really how you have to use quite a few tricks up your sleeve to make a good evaluation. You do have to be careful because in this breed particularly, you can often get a breed-related lateral strabismus, which we call an exotropia. So it is not unusual for the Cavalier King Charles Spaniel and other toy breeds to have a tendency for their eyes to deviate out laterally. So this has to be taken in context with the remainder of the examination as well. So abnormal spontaneous movements. This is quite a complicated slide, and we're not going to go further into it in this particular introduction to neuro-ophthalmology, but just to say that this is an a whole dedicated lecture for itself. And so we will divide the abnormal movements into nystagmus, which is a backwards and forwards type of movement, or an up and down type of movement. And then we have abnormal saccades and smooth pursuits. So saccades are the rapid eye movements you make to track objects, and smooth pursuit is what it sounds like, is how your eyeball follows a traveling object, or when you smoothly go to watch something. We can have abnormal saccadic movements. These can sometimes be very difficult, I find, to tell the difference from nystagmus. The classic nystagmus is vestibular, where you have a kind of jerk movement, which can be either spontaneous or positional. So with a vestibular, you get a kind of fast jerk to one side, and then a slow movement to the abnormal side. So it's and I should say that really goes the other direction, so you get a sort of slow drift to the side of the lesion, then a fast jerk back, correcting it. So it's drift, jerk back, drift, jerk back. You can also have congenital nystagmus, which tends to be pendular, and you can also get what is called amerotic nystagmus, which is more random movements which occur when the animal is born congenitally blind, especially from hereditary cataracts. And this dog here, I really couldn't make my mind up whether this dog has a congenital nystagmus or whether this is an ocular flutter. I actually think, because it kind of changes direction, that it's more likely to be an ocular flutter, which is a high frequency, high velocity saccadic movement, and kind of oscillates around the midline of fixation, rather than being kind of there all the time. Because when the dog moves its eyes, you can see it kind of being more obvious. And then we have a convergence retraction nystagmus, which I'm not going to go into further right here. So the next thing we need to look at is whether or not there's any abnormal position of the eyelid. So the eyes that influence eyelid position are the oculomotor nerve, the sympathetic supply to the eye, and the facial nerve to a certain extent. So the facial nerve is kind of supplying the orbicularis oculus round the eye, whereas the actual innervation to the eyelid, the main one is the oculomotor nerve, which is the levator palpebral dorsalis, so the actual eyelid, and the sympathetic also supplies some innervation there through to the dorsal tarsal muscle. We can also get ptosis because of primary muscle disease, but you can also close your eyes because you're painful. And so ptosis is not necessarily neurological. And here we have all of those examples here. So this little guy here has Chiari malformation associated pain, and we presume that he's having some signs of headache or similar type of head or eye pain here. When I sort of put the video on here, we can see he can open his eyes, but he really doesn't want to. Whereas this girl here has a Horner's syndrome of her left eye, and we can see the obvious ptosis, narrow palpebral aperture here, and we can also see that her third eyelid is coming across right there. We can't see whether or not she has a pupil constriction. This girl here is the girl that we saw before that has an acute oculomotor nerve palsy on the left side. Her palpebral droop is not so obvious, mainly probably because she's rather nervous in this situation. So she only has a partial lesion at this stage, but I think you can appreciate that this is smaller than that. However, as time went on, this became much more complete. Actually the strabismus became permanent probably because of muscle contracture, completely unopposed from the outside, and you can see that the opening of that eye is much more restricted. This little girl has a chronic facial nerve paralysis on the left. In the acute phase, you don't see any particular droop here, but in fact the eye may be more open more widely, but as time goes on, the muscle becomes contracted and you get that narrow palpebral aperture. And whereas this guy has a weakness of all the extraocular muscles, he has an extraocular myositis. So 5 different examples of ptosis there. And that's where we're going to end this lecture. In later lectures in the series on this ophthalmology, we'll be going into central blindness, causes of strabismus, causes of nystagmus. So look out for those. And in other lectures on the cranial nerves, we're going into the trigeminal nerve, the facial nerve, and the bulbar nerves. Thank you very much for your attention.